Next up, we have Kwasi Bohain. I hope I pronounced that correctly. A doctor working in the sub-Sahara area. Cheba and I were observing yesterday, we are here representing 5 continents. This is a truly global movement. And so to talk about what the work that you do and share it with your panelists. I know you used to work with Joep Lange. Yeah? A famous Dutch HIV researcher. So I know your work is cancer and beyond. And over to you for the panel.
Thank you very much. My name is Kwasi Bohain. I'm with PharmAccess. So PharmAccess was set up by Joep Lange, AIDS researcher who died on the way to AIDS conference in Australia, in Ukraine. The plane was shot and we still don't know who did it. So we are involved in using innovations to ensure that the financing and delivery of care will be sustainable. It's not a matter of providing care to people now because there's project money, but how do you ensure that in the long term, people will have access to care? So that's what we do. And then work in several countries. Peter, who is here from Ghana, is an important partner of PharmAccess. And I always say that, Peter, I don't know whether everybody knows you. Yeah, so Peter heads a federation of Christian-based healthcare facilities in Ghana. The network that he heads, they constitute only 7% of healthcare facilities in Ghana, but they deliver over 1/3 of healthcare services in the country. So if you see Peter, we're talking about efficiency and innovation, and it's an important partner for us. So we're going to talk about multi-cancer early detection, and we all know that it's a new approach where with a single test, we'll be able to identify multiple types of cancer. And I think it's important because early detection is critical for effective treatment, but also to ensure that there will be less invasive treatment. And certainly, if you can do that, then we're talking about survival rates going up and ultimately higher outcomes for patients. So that's what we're going to do. But before we go that, let me say something about why I'm here. You know, in Ghana, we say that anyone who thinks that he or she is small for change has never spent a night with mosquito. and I guess, yeah, meaning, you know, small mosquito with determination can cause a lot of change. And I guess, so we see that determination is critical. And I think if you come to Europe and maybe in the Netherlands, what I also see is, I see a lot of windmills. And I always say that windmills, they have value when there is wind, meaning that you need resources to make things happen. So if you bring determination and resources together, you can achieve a lot. And that's what I consider very inspiring for Inspired to Live. Also, talking to Peter, Ilona, and Eljo about the efforts that they are making to extend patient advocacy, treatment, and etc. to Africa. I think they deserve a wealth of applause. And whatever we can do, from PharmAccess perspective to support the building of partnership, we will certainly contribute towards that. So we're going to talk about multi-cancer early detection, and I have a panel of 4 people, very experienced in their fields. I have, they will come here later, but because 3 of them will have a presentation, if I mention their names and whatever they are, they can stand up so you see them. So we have Dr. Mau Mau, founder of Seeking, and I'm sure you know a lot, so for the sake of time, I won't go into the CV. And then Professor Sarah Sukuma from Professor of the Hopkins University, Professor Ifeoma Okoye, Professor of Radiology in University of Nigeria in Nsukka, and then obviously Professor Yaredi Koning, Professor of Public Health and Screening Evaluation in Erasmus University. So what we're going to do is we will start with 3 short presentations for the benefit of those who don't really know the nature of their work, but also to put this conversation into context. And then after that, we will go into some questions about the science of multi-cancer detection. We will talk about its accessibility and then the future. And then, we will open for discussion. We have 1 hour to do that. So we will start with Mau Mau. Thank you very much.
So I will do another rapid fire talk. It's all because, yeah, I know. It will be less than 10. So, because this is lunchtime. Okay. This is a real lunchtime now. And also, just I want to go through it quickly so we can have enough time for discussion. I think the discussion is more important in this case. And what I'm going to do is show you 3 things we have done in the past year. So this is more like my annual report to the board. So you are the board today. And I think you're kind of familiar with the ONCOSEQ. Many of you had that yesterday. So this is what I reported last year. So we had 3 cohorts, then roughly 10,000 cases in this case. So not only 2 cohorts from China, but we also had the cohort, the Johns Hopkins data. So we can evaluate. We had 2 sample types, plasma and serum. So the both are used for this type of analysis. So not just the Roche platform, we also have multiplex, the Bio-Rad platform for this analysis. In the past 1 year, we add 4 additional cohorts. And the first one is ELISA platform. So this is a very basic manual platform to analyze proteins. And the second one was from Brazil. So now we have another country here. And this is in a prospective setting and also blinded. It's double blinded actually, because for those individuals, we didn't know, the diagnosis of those individuals. And the third one is, this is one we believe, so we are going to move forward with this test, that is the symptomatic population. And so we can discuss later why we want to start with the symptomatic population instead of doing, a screening. So this is exercise to look at what the performance in a symptomatic population. Can we help cancer diagnosis using this blood test for multiple cancer types? And the last one is we're looking at a different platform. So there are 2 very popular platforms for protein analysis worldwide. So one is the Roche and this one is the Abbott. So that means we can fly Boeing airplanes. We also can fly Airbus. So we cover them all. So we put all 7 together. Oh, why I cannot move it? I cannot move my slides. I have a problem to move forward my slide. Ingrid? So I cannot move my slides. I don't know why. Yeah, so.
Pointer as well. Can you use that one?
So which one is, this is forward?
I think so. Hope so.
No, it's not moving. Oh, it's here. No, it's not moving. It's stuck. Okay, so maybe exit.
So here you are. No.
Stuck. Okay.
Okay. Strange.
Maybe exit.
Hold on. Yeah. It's all stuck.
Okay, so basically we're at for the addition. So basically we add 4 additional cohorts. So now we get similar results as the previous result, means similar sensitivity and specificity. The sensitivity is a little better because we add the symptomatic population, because we have more late stage patients in this case. Right, so we can also discuss later. So, to do the screening, so again, so we need more data, especially the prospective study, and, to use this as for patients, right? Because these markers are already widely used in clinic. So these markers certainly has a value for diagnosis, right? Like, if you see an elevated AFP, so this is liver cancer. So we think we can start from there. And also we discussed, right? So we also like to do a prospective study in the symptomatic population. So we believe that's easier. We also can discuss, why.
You also said the levels were higher with that cohort?
Yeah, because that cohort is symptomatic, because we have more late stage patients, because, the study was in China in a cancer hospital. So we have more early stage, in the real world. Yeah.
Yeah, Sabine Lin. I'm a breast medical oncologist from the Netherlands Cancer Institute, and I'm really interested in this new development. And I wondered, so of course you have a dream, right? So what is your dream, let's say 5 or 10 years from now? How will your test be used in the clinic, and how will people benefit from it? So what will be the optimal outcome of the project?
I think the optimal outcome is, so we started to use MSAT, the multi-cancer early detection, for screening. So I believe that is a more effective and also more cost-effective way to do screening. So one thing is, right, so we have screenings for, those cancer types in guideline, beyond those ones, so we don't have a screening for those. And also, we also have to understand, so from the commercial perspective, actually, if you have a good test for pancreatic cancer, but that is actually not commercially viable. So we also have to consider those reasons. And also for rare cancers, you can never develop a test. And also, even you have the test, you have no way to validate the test. So that's why I said, so we need a test, one for all, on top of what we have today. So that is my dream. Yeah, to be used. Yeah.
Okay, and so let's say the test, I do the test and it's positive. Then what's the next step?
Oh, the next step is, so we have an algorithm called the tissue origin. So we can locate the cancer based on the profile of, the data we have. So I can also show some data about the tissue origin.
So then
we do have a prediction for the cancer type.
And then there's imaging.
Then we'll be imaging.
And if there's nothing on imaging?
Right. So so their studies have been done. Right. So we have the tissue. So the follow-up will based on 2 things actually. So one is this prediction. The other one is symptoms. So the symptoms will also guide to look at which organ. So if it's negative, so so we will do retest in 6 to 12 months. And in the meanwhile, to look at, the symptoms these kind of things.
Hij komt al.
Okay.
That's the follow-up for negative findings. For positive, test result, but negative findings.
And you will reassure me that I don't need to worry? Well, of course, I will get a little bit worried then, right? And so how are we going to manage the worry? Because then there's nothing on the scan, but the test was positive.
Right. So we worry a lot of things.
Yeah.
So you can always argue, so this is like a hurricane. So this is a false alarm.
Kijken, welke is het?
Yeah.
But they are real hurricanes.
Yeah. Okay. No.
Yeah.
Nee.
The accuracy probably to predict the hurricane, by this test is like 70%.
70.
We do have false negatives.
Presentatie is
Yeah.
toch weer?
We certainly have false negative, false positives. Those are, bad things. Those are, are problems. But again, there is a value to do it. That's my point. Again, we will argue
Oh,
this
het is ongelooflijk.
in the panel.
Yeah. Nice. Yeah.
Oh, we're
Yeah.
back.
But we're back.
Finally.
Okay, so
So you can advance and do that, sir.
okay. So let me do 2 minutes. Oh, it's stuck again. Oh no. Oh, okay. All right. Okay. So okay, I skipped that part. I 1 minute. I tell you. So we have a blood-based lung cancer test, and so same concept. We did 3 cohorts, and this is an important slide. So basically, so we have the specificity at 90%, and the sensitivity is 84%. Based on the data we have today, 3 cohorts, case control study, and we look the other tests in the same setting, still case control study. And the early CDT lung is the most popular test for now, developed by University of Birmingham and launched by a company called OncoImmune. Because of that test, OncoImmune becomes a public company and acquired by American company this year. So you can see the numbers. We have pretty much the same specificity, but our sensitivity is much better. Okay, and also you can look at, what would be the retail price for the test. And the other test is the newest one based on the most advanced technology, NGS fragmentomics. So this is, the best science, right, today. And now, so the work was done in Johns Hopkins, and also now there's a company called Delphi is providing the test in the United States, and also they're doing large studies in the Netherlands about the clinical utility. And you see, we have very similar sensitivity, but our specificity is much better. Okay, just based on numbers, based on what they have published. And we believe this blood test should be used before the low-dose CT. The low-dose CT is a good way to scan lung cancer, but the biggest problem is the false positives. And like if we use LDCT to screen all the Chinese, we'll have 100 million Chinese be positive by low-dose CT. You will see nodules there. So because the false positive issue, and also this just to show you if we do the lung cancer first, then low-dose CT after that. So how many cancer cases we can detect it, and also what's the cost and what's the false positives for this so-called 2-step way to screen lung cancer. Okay, so the last thing, so we know MSAT will come out, and also so there's a test called Gallery in United States again. So so very advanced technology. $4 billion have been spent for this particular test. $4 billion. Okay. Have been spent for this test. So so the test is close to $1,000. So it's a good test, but I think the biggest problem is the cost. So we are proposing to use OncoSeq as like a PSA or fit. So start with that. So then use Gallery or our own the NGS test for the as a secondary reflex test. So we can reduce the cost in this case. So we can do a population wide screening. Sorry, take a long time.
Thank you very much. And unfortunately, that the internet or the computer didn't want to corroborate. If you can take your seat there, then we go to Sarah for 10 minutes presentation on her work.
Thank you. Thank you very much. This is a wonderful opportunity, my first time at this meeting, and I must tell you, I'm so moved by the passion and the real power that is behind these voices of all of you sitting here. So my story is a journey, and I just want you to sit back and relax for the next 10 minutes. As I go through this narrative, out of Africa, developing automated assays for early detection and monitoring of disease burden in breast, cervical, and prostate cancer. I'd have to shorten my talk just because of the paucity of time. So here we go. Next. Yeah, okay, I'll do it this way. No.
Yeah, no, it works.
This
Just use it.
down.
Yeah, up and down. Or left and right.
Okay, very good. I'll pass that. So my journey started with friendship with Susan Harvey, who's shown on the left, who's a radiologist and who was really trying to get ultrasound training into Africa so that she could have early screening begin for these women. They have nothing. They have no mammograms, no screening. When they come in with lumps in their breast. And these lumps may be as small as a pea, or they could be as big as a lemon. It's really true, and I've seen this with my own eyes. But who made it possible is Maureen Jaffe on the right, who heads the WITS Foundation. She works there, and she's a mover and a shaker and gets everybody under the same umbrella for the studies that you need. So off we went from Baltimore to Johannesburg to see what it was about, that what are we dealing with, who are we working with. And in South Africa, there is a hospital called the Chris Hani Baragwanath Hospital in the Gauteng province, the poorest of South African provinces, most populous, 10,000 patients a day streaming in these white taxis. It's like a mile after mile after mile of these taxis bringing the patients in, and they are looked after in this hospital. Now, what about breast cancer? They have one clinic day, 200 people appear on that day, and the incidence of breast cancer among the women with lesions is 60%. 60% of those women have lesions, so that if you just take, oh my God, it's really mind-boggling, but they get through the entire 200 population in that single clinic day. So what's the excitement about? What are we doing there? So we found through research since 1990 to 2016 that hypermethylated genes are commonly observed in breast cancer. What are hypermethylated genes? It is DNA stays as DNA, but on the cytosines, they acquire a chemical modification which is called a methyl group. When they acquire this on a series of cytosines next to a promoter or the driver of a gene, that gene shuts down. So it's a very neat way of shutting down the expression of tumor suppressor genes. And it may be also a very good way of activating genes when those methyl groups are dropped. So it's a reversible reaction. Is it important only in cancer? No. Multiple diseases have this phenomenon where they shut down the expression of genes at certain times and open it up at other times. This reversible nature is very, very important to their functioning. So tumor suppressor genes are shut down by hypermethylation of those genes by cancer cells specifically. So our story is that we discovered a large number of these hypermethylated genes in breast cancer. Then we selected some of them through a very tight selection procedure to have only panels of 6 to 10 genes that could detect any type of cancer in any country in the world. Why go global? Why not stay in the United States and develop these assays for the United States or the developed world? The magnitude of the problem, the global burden of breast cancer is increasing, and breast cancer is the second most common cancer in the world, and it affects women everywhere. Now, what is the problem? See, the blue bars are the incidence of breast cancer in the developed countries. That's to the left top. And the mortality is in the red bars. As you come down, you see that the blue bars are decreasing, and that is the less developed countries, but the red bar stays constant, which means that the incidence of breast cancer is far higher in the developed countries than in the low and middle income countries, but mortality is very similar in both low and middle income countries and the developed countries. Why is that so? The reasons for the disparity is known to many of you. Disparity in timely collection and care is responsible for most of the cancer deaths, and lack of screening. Minimal hospital facilities, delayed diagnosis, and few pathologists per population. Even in South Africa, which is considered a middle-income country, there are delays for up to 1 year for some of these patients, which I also happen to witness. So mammography is impractical due to costs and difficulty in implementation. So what is the solution? So our vision is that we could develop a test that would enable rapid prioritization of the patients with suspected cancer for further pathologic evaluation and care at a regional care center. Why don't we take this test straight to the screening center? And I say, no, don't set yourself up to huge hurdles. Go downwards in difficulty. First, set up the easiest place. And the easiest place for us was to go to this clinic where these women were undergoing fine needle aspirates for cytologic diagnosis, which would take a week or 10 days or even a month. And from that same fluid, we can do this test, which takes only about 4 to 5 hours. So we can prioritize the patients, send those who have cancer right up to the front of the line so that their care could be expedited. So we identified through a lot of research a 10-gene panel that distinguishes between benign and malignant disease. We set our bar very high. We wanted at least 90% sensitivity and 90% specificity of detection of these tumors. Now, we found out, and this is all published work, so I'll go through it very rapidly. The same panel of methylated genes performs equally well in 3 different ethnic populations. So we always look at least Africans, the Chinese, and also the Caucasian population, so that any population in this, and we have analyzed more than 500 of these cases, we find that our panels is as strong in one population as the other. And whether it is a different IHC subtypes of breast cancer, it still functions very well. So the assay displayed high performance characteristics in a pilot study of archival FNA specimens, which we got from Hong Kong and from Portugal. And armed with this information, what we did was to collaborate with a company called Cepheid, who produces the Gene Expert system, very popular in Africa for detecting tuberculosis. And the reason we went with this company is the machines are already there. So all we have to do is to put this little plastic cartridge with a different set of chemicals into that same machine. So how does this go? The FNA from the palpable breast lesion comes on slides to us from South Africa. We just add it to that tube, shake it, and put it into a cartridge that converts it by bisulfite and to a different reaction, and then we transfer it to the 2 cartridges. That was very promising, but we wanted something that is inexpensive and single cartridge automated assay. 3 cartridges are more expensive than 1. And so we did our experiments to make sure that we were able to make it into a single cartridge, that indeed we removed that cartridge and the bisulfite cartridge, and we were able to use just 1 cartridge with a panel of 5 genes and actin as a control. Does this work? So this is our preliminary assay that of the samples that came. There were 66 invasive ductal carcinomas. These are all fine needle aspirates, and 48 benign samples. And what we saw was that indeed we were able to achieve a sensitivity of 91% and a specificity of 94%, higher than what we had set our goals for. And the threshold for normal is 15.5 centimeters, cumulative methylation unit. What does this picture show you? Each color is the extent of methylation in each of those genes. And so we just pile it up for each patient, and we've shown it in a flow chart where the bottom 3 patients were not detected, and 1 of the greens was false positive among the benign. So what are the advantages of the GeneXpert cartridge system? The simplified assay, data analysis, and interpretation are all automated. So that leaves very little margin for error, and this newly developed methylation cartridge could be easily adapted for detection of other cancers. And I will just show you a single slide of each of these other cancers. A positive assay will lead to expedited pathology and treatment. Eventually, we want this in the screening setting where they will be able to detect what we think are malignancies and allow those and warn those patients to go rapidly to the secondary and tertiary facilities. That we are now doing testing the clinical utility of this in a very large study of 750 patients in South Africa, and the validation studies of 560, and it is really rapid accrual in this. This is funded by the NIH. We are just in the 2.5-year time point, but we have already 517 out of those 720 patients accrued. There is absolutely no problem in enrollment. Enrollment is 96% of the women you ask will say yes. So this is an amazing thing for us, that this is happening so fast. So our vision is fast detection of breast cancer in screening centers. We are instituting a screening with ultrasound combined with AI to find what might be suspicious lesions. You put a needle in there, you take some fluid out, put it into this cartridge, and at the end of 5 hours, in this case, it will be only 3, we will know what the answer is. When you know what the answer is, you use a second cartridge that does ER, PR, HER2, and Ki67. That is for the subtyping. So at the end of the day, if the woman says, I will not come back, I have 5 kids at home, you give her a handful of oral tamoxifen pills and send her home. You'll save her life. 70% of the women will have ER-positive breast cancer. You will extend her life at least for 5 years. So we feel this is a terrific vision to have, and we are indeed moving along really fast to see whether our vision is become reality. So Cepheid has more than 25,000 of these instruments. Mini-operated battery units are also available, single units, which can be transported on the back of a motorbike from place to place. The impact will be that millions of women will be screened by ultrasound, automated diagnosis and subtyping will be performed, and treatment will start rapidly. So screening and timely diagnosis is key to reducing mortality due to breast cancer. I'm going to go through rapidly the single slides of other cancers that we are tackling. We are tackling prostate, the colorectal, and the cervical uterine. These are huge numbers, 1.4 million and so on, for incidence, with more than 400,000 dying each year. For cervical cancer, this is also published data. Why do we need it? Simple. They want a test that can distinguish between the low-grade squamous intraepithelial lesion and the high-grade. Low-grade doesn't have to be treated. It disappears over time. High-grade needs to be treated. How do you distinguish between these two? Can our markers do that? So we did a pilot study of 250 samples of liquid-based samples from a screening clinic in South Africa, and this is what we find. The green, the NEIL, means there is no lesion, no intraepithelial lesion. You can see how low the methylation values there are. The low-grade cells, very low. Now, when you come to high-grade cells, you begin to see methylation. So if it is methylation positive, at least 80% of the time, we are able to detect that it is an H cell and not the low-grade cells or squamous cell carcinoma. Squamous cell carcinomas will all be positive. So we think we may have a test here. It needs work and it needs a much larger study. So what do we want to do next? Develop an affordable, simple to use PCR methylation detection test. We need a commercial partner for this. Cepheid is not interested. So we are looking for a partner, but next let me just show you a single slide of colorectal cancer. You can see that our test is able to detect as you see on the left top is what is called a box plot. It tells you how low the normal is and how high the cancer values are. This test is done in 1 milliliter of plasma. The DNA, that is the cell-free DNA extracted from a single milliliter of plasma, a liquid biopsy test. And the AUC here was 0.996. That is, the test will be accurate 96% of the time. Now, that last one is prostate cancer. We have 111 and benign. You can see what the difference, what is the amount of methylation in the cancer versus the normal. You see there that the AUC, the sensitivity specificity is extremely high, 0.995. And you see that if you just take 2 of those genes and combine it with age, you are able to get an accuracy of 0.79. Never heard of before, not in any published literature. So to conclude, in South Africa, detecting breast cancer using FNA, we are prioritizing patients with cancer for expedited care. In Nigeria, for detecting colorectal cancer among patients with chronic GI bleeding and other symptoms, these patients are undergoing colonoscopy. And we choose these settings because we absolutely need histopathology as the gold standard. Yes, and there 70% are benign and 30% are cancer. So who are the cancer patients? Who need care? How can we take care in these places that really do not have the resources to be spending it on the 70%? They want to spend it on the 30%. How do we do this? How do we select these patients? And this test might be able to do that. Similarly, prostate cancer, there is no test except high PSA. So here a test in a urine or blood is being developed. Again, there is right now no PCA screening. We might be able to do that. We might be able to also monitor the load of disease as a patient is undergoing treatment. So a blood test to distinguish between low and high-grade prostate cancer, monitor the response of metastatic prostate cancer to therapy, and detect disease recurrence. And with that, I shall stop.
Thank you very much. I think we will take the questions when we come to the discussion side. So, Harry, the floor is yours.
So I'll just wait for the slides, but good afternoon, everyone. Thank you very much for the invitation. It has been an inspiring morning for me already. I hope, and let's say 20 years ago, we published that it would be cost effective to do CBE screening, clinical breast exam screening in low and middle income countries. And I was so happy to see this Egyptian program and what we saw just now. I hope you don't see me as the messenger of bad news, but how should I go forward, just to be sure? Yeah, where? Just. Oh, like that. Yeah, we do that? Okay, we'll try that. But my career is that I've been working in screening evaluation for more than 30 years now. I now have a team of about 45 people doing research on screening and in all sorts of things, many cancer screening, but also non-cancer cardiovascular disease, even screening for child abuse at emergency departments. So that's a bit my role. Again, I try to do this really in 5 minutes because time has run by, I think. But I just want to show you a bit of realism at the moment. We go indeed to a new situation. Indeed, can we not have just one test can we not have just one blood draw? The problem is here you see we have good programs for breast, cervical, colorectal, lung, and prostate. Prostate debatable and not yet running so swiftly throughout many countries, you could say. But nevertheless, I'm also convinced that a good prostate cancer screening program is good. But it means that we still have about 80% of cancers where we have no test. That's the issue. And this multi-cancer early detection test basically means that within the bloodstream, there are all sorts of things. Protein, DNA, fragmentomics of the DNA, etc., etc. And why not look at that? Breathomics is also one, of course. Oh, every time. Yeah. This is an abstract from just maybe a couple of months ago where a group has tried to get all the information from all tests together and made a summary. And here you see, let's say, if you look at sensitivities on the column on the different diseases, and let's say it's about either single early detection test or multiple cancer early detection tests. And these sensitivities, they look very, very favorable. 80%, 90%, 70%, etc. That is really good, true. But the big issue is, of course, what is the sensitivity for the early stages? We want to do screening, then we need to get these early stages in. And there is a big difficulty still. I think what we see now is that many of the sensitivities, so sensitivity means how many of the cancers that are there already in the body are we picking out? And that is still limited, unfortunately. And that's why this debate that we will have in 3 minutes is so timely. How to go forward? How can we improve this all together? But the main point is, okay, can these tests really reduce cancer-related deaths? Can they really reduce the incidence of advanced disease? Can we really find cancer in the difficult ones, the ovary cancer, the pancreatic, the liver, etc., etc. And of course, the issue: who should then get this test, and can we then find indeed if the test is positive? Can we find the risk? Can people then skip the other proven cancer screening tests, or will they do that? That I think should not be the case, but nevertheless, and do they work for everyone the same thing? And do we not indeed get higher socioeconomic disparities, actually larger ones? So yesterday, actually, in the cancer letter, I quoted this from Don Barry. You could say Don Barry, I know him relatively well. He is a statistician and he is very much in favor of treatment. He's not so much in favor of screening, but he learned, I see him regularly, let's say. But still he quotes, of course, that screening can always increase the cancer rates dramatically. That we are certain, but what is uncertain is whether it really decreases cancer mortality. So one needs appropriate clinical trials to address that. There are all sorts of trials running at the moment. I will skip this. But unfortunately, in the cancer letter of yesterday, I found this. The grill test is the hype at the moment. I think, as I said, there are more out there. But the firefighters in San Francisco, they said, okay, let's give $1 million. We do this test and see what happens. And unfortunately, here you have about 1,800 people getting this test. 5 cancers detected, which was much lower than expected, but okay, 5 cancers detected, 6 false positives. Again, you could say 5 and 6, I would not, that's unfortunate, but is all in the game in screening. But unfortunately, what you see is of the 5 cancers detected, 2 were already known, and 2 were cases that at some point became simply advanced disease, unfortunately. Lung cancer with brain metastasis and pancreatic person now in hospice. And there were 6 cancers missed. And you could say, well, maybe melanoma, prostate lymphoma, maybe not that bad. I don't know how to realize. But anyhow, this again is still realism now. Again, I really think we should look at how to do all much better, but this is also reality. So I think Don Barry wrote something about trials. I also wrote something about trials. And The Emperor of All Maladies, if you haven't read that book, I think you all have, I think, or not. But if you're in the cancer field, The Emperor of All Maladies is a nice overview on the cancer involvement, the research, etc., written by Siddhartha Mukherjee. And I'm not saying it because I was quoted in that book, but still, this is my quote somewhere, that indeed randomized controlled trials are bothersome. It takes ages to come to an answer. They need to be large scale, but unfortunately, I think there is no alternative. But anyhow, I think that's the debate we have to have. So I think one of my final slides, Justice Never Dies. If you are into graphic novels, please read 20th Century Boys. Very, very interesting manga. Justice Never Dies. So indeed, I do hope that these new tests will become the future. I certainly hope that. But I think indeed, for the discussion, I'll take a start. Let's say, look maybe on the right-hand side. To get this done in the Netherlands is very difficult. We have a population screening act. We have a health council in the Netherlands. It means this kind of research is almost impossible in the Netherlands. But we should have a European perspective study maybe needed. We could do site studies in running cohorts. We have so much focus on personalized care, so why not do this kind of research? We should do modeling. Well, we'll get this debate, I guess, running now. So I stop here. Again, I don't want to bring you bad news. I really hope this is working out, but we really have to do something to get this all better. Thank you so much.
Yeah, so we heard from Sarah, Mao, and Harry, and just to keep the conversation going, Prof, if you can discuss, I know you spoke yesterday about the work that you're doing, but anything that you need to add on the basis of the conversation that we're going to have now. Yes.
Thank you for the opportunity, and I want to thank my fellow panelists for the profound work that you're doing. I'm still an advocate of little drops of water. Definitely contributes to make an ocean. So I want to just use my time, instead of going through what I had talked about yesterday, to draw attention to some of the efforts we have been making to mobilize some of the technologies in healthcare, to add to the efforts that we are making to disrupt that late detection journey that is contributing to high mortality and morbidity in our sub-region. So we looked at, as I said yesterday, collaborations, partnerships, and that has helped us a lot, both to upskill and also to begin to be players in the arena of this utilization of disruptive technologies that are showing up in the healthcare sector. So, for instance, we have looked into how we can utilize artificial intelligence. We looked at how we can leverage telemedicine in my institution, and we have also worked a lot on developing clinical trial units, which was what the United Kingdom utilized when they wanted to leapfrog their clinical trial industry. So we looked at this model in Clinical Research Center in South Africa, where we launched the first outside of Nigeria summit of the African Clinical Trial Consortium. For this effort and solution, which we devised at that meeting in South Africa, I was actually elevated from being just an Ashoka Fellow to be an Ashoka Globalizer Fellow. And for 6 months, myself and the director of the Clinical Research Center in South Africa were put through a training in order to help us to scale and have this disruptive solution of developing clinical trial units as a way to scale the volume of participation of African nations and participants in the clinical trial industry. So we are still working on it and trying through the African Union to see if the national governments can, have a buy-in and agree to adopt this and have at least 2 clinical trial units per African country. Because we see it as, when you operate on the level of focused clinical trial units, you find that you're able to bring out more trustworthy data because your GCP compliance is not affected by a busy clinician who is trying to run a clinical trial from his clinic. So you have people that, different categories of team members, site, coordinator and all that, who are truly just focused on delivering that clinical trial. And usually you're able to do that for multi-disease area, so it's not mono-disease areas. So we have been utilizing the clinical trial units, which I'm the director of at our university. It's called the University of Nigeria Center of Excellence for Clinical Trials, and we have used it to leverage ourselves and to be part of multinational studies like the Amplitude study by Vertex, which is looking into APOL1 disease. So just quickly going down to our area of focus, which is cancer. What have we done? As in radiology, for instance, we are looking at how we can address infrastructural gaps and leverage technology to overcome workforce and resource constraints and ongoing efforts to address certain limitations in radiology practice in Nigeria. So I'll quickly go to that aspect. What we have done with Stanford University is still ongoing, and I want to just talk about it because it's interesting, and we can actually multiply this effort for all other institutions who might become interested in partnering with us and in collaborating with us. The issue is when we develop AI solutions and there is no inclusion of participants from certain areas of the globe, you are not able to be sure that your precision medicine, which you are aiming at, will be achieved, because that exclusion would actually cause certain errors in that interpretation. Sorry. So,
You can run off.
sorry.
You can run off.
Yes, I'm trying to present from my phone. So what have we done with Onset? Onset collaboration with Stanford, we partnered with a local, a national technology startup to build AI software using imaging data from radiology centers in Nigeria. And we anticipate that including our images will be accurate for Nigerians because it was trained using 100 images from Nigeria. The AI will be able to read X-rays, ultrasound, CT, and MRI scans, and we are actually targeting mammography as one of the first port of call. Also, the AI is expected to be able to predict the genetics of the tumors seen on CT and MRI scans through eventually coming up with radiogenomics based on this data. When the AI is developed, we would clinical trial test it with Onset, which is the Clinical Trial Center, Stanford, and UPenn, the latter two in clinics in the US, seeing majorly Black Americans. If we succeed in the clinical trial, we would apply for the AI to be used in clinical practice in Nigeria and also in the US. So what we have been able to achieve so far in terms of creating what we've called the Stellar. That's a training AI application we are benchmarking it on the Stanford Electronic Learning Library and Applications, ensuring representation of Nigerian images in the AI training tool. So the reason for this is to support residency training and radiology workforce upskilling. Their laboratory will investigate the use of deep neural networks and other machine learning technologies to detect disease and eliminate diagnostic errors. Screening mammography, being the primary tool used to screen patients, is what we have focused on. And given that only 3 to 10 cancers are detected per 1,000 mammograms interpreted, there is an inherent weakness in breast radiology training. So over the course of 4 years of residency, the results we got from the studies we did was to show that residents typically interpret less than 500 screening examinations, and over a 1-year breast imaging fellowship, fellows typically interpret less than 1,000 screening exams. This results in trainees of all levels being exposed to too few screen-detected breast cancers. So the goal of this particular effort is to improve screening mammography training and to increase breast cancer detection and accuracy of mammographic interpretation, and provide access to mammographic training free of charge.
All right, thanks. I think we will come to some of the challenges that you're discussing, because if you want to have good, credible early detection tools, we really need the skills and the capacity to go with it. So thanks a lot. We will follow up with some specific questions. I think, you heard the presentation from 4 of them. You have Sarah and Mao talking about what they're doing now and the value that it creates, focusing on people who are suspected to have cancer. And of course, that's important because in the context, in certain contexts, you really need to embark on that campaign. And then, of course, the conversation from Harry about, it's about early detection. So we're talking about the predictive tools of the various tests that you have. And I think the two can go together, but of course, it's also important to see how the single cancer early detection can feed into the broader agenda of multiple cancer early detection. If there are specific questions that you have based on what you've heard, yes.
Thank you, everyone. That was a great panel discussion. Sarah, this is for you. I just want to know, you might have mentioned it. So when you're using the Gene Expert, so how many samples you can process at a go?
It's unlimited. So the machine comes in units of 16. So you can have an entire wall, as I saw in South Africa. This hospital had this full wall full of machines because that's how many tuberculosis tests they do.
Right.
Yeah.
Right.
So
that's the reason why
I was told that each person I spoke to from Africa knew the Gene Expert machine, which was very heartening. That means that they know that this machine exists.
And what is the cost effectiveness? Like, suppose you want to take it to the very rural area, interior area. So what is the cost? Is it covered under the government funding or?
So the cost will be of the cartridge.
Okay.
Because the machines are there. I don't know the cost of the machine, but the cartridges for tuberculosis, they're selling it at about $8 to $10. And that is, I'm sure, with some subsidy from the government and so on. So I'm keeping my fingers crossed that they'll come to that cost.
Okay.
In the lab, we can easily do it within $8 to $10.
Okay. So I will have a discussion with you separately.
Yes.
Many thanks for all the wonderful talks. One thing that I want to bring out here for discussion is that, we are talking a lot about false positive results. And I know how many histories of women that went to a mammography and it was a false positive, and then become afraid for months because did it once, and then the physicians ask it again, let's try another one with a better image, and then you do it again and it's mash it up, it hurts a lot, and then okay, let's do a biopsy, oh, it's just a calcification, and you get relieved, and you never think about it was a false positive. I never heard about how many false positive do we have in the mammography. We don't worry about it. We are just glad that you can have it, that we can prevent it. I understand that we also need to think about a burden of cost. It needs to be sustainable. But for my life, the worst thing is when I heard about a person that was complaining about a pain and having lots of exams, colonoscopy, you are lots of blood samples, they discover nothing. Oh, I'm with 2 years in this belly pain. And then when they discovered, it's already late. There's too many histories like that. Don't you think that for me, for my life, how much does my life cost? It's infinite. There's no value. We know that. But for my life, the most important data that I want to see is the false negative, because you were there, you were looking for help, you were looking to find something, and you tried, you said, you asked for help, and you didn't have it at the time that you needed.
What can we do to improve the accuracy of the test, basically? Yeah, please. You can get it. Yeah.
Thank you. Yes, indeed, you're right. So often false positives are mentioned. It is a harm. Overdiagnosis is a harm. But you're right. False negatives is an important one. So it means that indeed you think you have had your test, there was nothing wrong, and in fact, within the 2 years later on or so, you get detected with a cancer. That is why I really think you have to have high quality screening programs. Then you are not dependent on an individual machine, on an individual doctor, on an individual practitioner who is doing right or wrong. In most of the programs, the breast program, the lung program, the sensitivity is in the order of 80 to 90%. So indeed, let's say between 10 and 20% we are missing the attitude, the machine, the test, or whatever. And that's very unfortunate, and that is what you of course can tell individuals, but they of course don't know what to do with it. But anyhow, so good high quality programs can reach these kind of qualities. And the colorectal program, if you just do the fit itself is in the order of probably something like 70% sensitivity, so 30% false negatives or something like that. So again, that's the plea for having a high quality program but online. Anyway.
Yeah, thanks. For the sake of time, I would like to have only one response to a question. So if there's no volunteer, I would choose. Yes.
Okay. Listening to you, Harry, one of our first board of Inspire to Live was Gerd Gigerenzer, and listening to you, I hear the words of Gerd Gigerenzer. It's about mortality. Yeah. So yeah, the screening will increase the rates of cancer burden, but how about mortality? So I think that might be a question for Mao and Sarah.
Yeah, I agree. So if Mao or Sarah, someone can respond, and because the question was screening will increase the rates, but it doesn't address mortality.
Right. So right? there are a lot of data, right? So there are well-established screenings about the mortality, right? So we know colon cancer screening, and so that's a very typical example, right, to reduce mortality, and also the lung cancer screening high-risk population. But I think I take the opportunity to ask another question, and also I ask for 30 seconds, okay? So go back to the mortality. If we use the mortality as an endpoint for HPV vaccine approval, there is no HPV vaccine today. Okay, we know how long that will take, how large the trial need to be, and no one is going to do the trial because it's not affordable. The same thing is, I still don't know. Today we have mortality data for HPV vaccine. I don't know. Okay, so that's my point for those new tests. Should we think differently? Right. The other thing I want to say, we talk about all these things. We talk about false positives. Certainly, if you don't do it, there is no false positive. Right? If you don't do it, there is no false positive. And on the same line, I would say, MSAT, we argued about, or the other screenings, is not going to kill you, but cancer will. Cancer will kill you if you don't do it, right? And the other thing, I also believe the multi-cancer early detection is the best bet to control the cancer deaths in your country and globally. Because we know how much cancer prevention can do, how much tools we have, and also we have the drugs, right? So, I've been doing, as a clinician, doing academic research and also in the industry to develop, HPV vaccine, drugs, and doing multi-cancer detection. Again, to think about it, right? So I do believe MSAT is the best bet to control cancer today. That's the best tool we can think about in the next 5 to 10 years. That's the reality. And the last thing I want to say, so we'll talk about we need to find the early cancers, but my answer is that's going to be very difficult or even impossible for human to do that. But then my question is, I think certainly if we put MSAT test there, we will find late stage cancers because this is a powerful tool to identify cancer patients. And my question is identify late stage patients a bad thing? Is that a bad thing? If we diagnose patient earlier, think about Nicole. I do believe if we had the test 2 years ago, she will be identified. Is that, early diagnosis only 6 months, is that going to be a bad thing?
Okay, I think
I think this is indeed a very good question, and you think, you think, surely it's good that we are earlier. But again, if you find a stage 3 or 4 earlier, it simply means that patient is for a longer time a patient. If he or she dies at the same point in time that she would have without the diagnosis, he or she has for a longer period of time going to hospitals, medical treatment, knowing the cancer. So that I think is not the way forward. Again, I'm as I said, I'm very hopeful that these tests in the next 10 years or so will really make a difference. I agree in those bad cancers, then maybe finding 40% of them early is still good. But no, I don't think the answer to finding late stage disease, that I think is not the answer. No, can be quite convinced about that.
Okay, thanks. Sorry. Yeah, please. You get the mic.
Yeah. Well, my question is more general. I'm interested how you see to close the gap that's now present with using tools for population screening, applying the same tools to this multi-cancer early detection, in spite of our knowledge that we at the same sex are different on, let's say, 5 million places in our DNA, that every tumor, even from the same tissue, is genetically very different, but yet we're still applying the same statistics. And I think that's, in my opinion, part of the problem.
Any observation? Yes.
So this question of heterogeneity looms large, especially when you're looking at breast cancer. And when we looked at the entire methylome for hundreds of patients, we yet were able to come up with a panel of 10 genes that was able to detect all the breast cancers, 96% of them. Yeah, we cannot beat that number. And this was not just a few hundred, this was hundreds and hundreds of samples. So I feel that yes, despite the heterogeneity, there are some genes that are always methylated, that it is essential for that tumor cell to have that particular methylation in order to go forward. Does each patient have all 5 genes methylated? No. They may have 3, 2, 1, etc. So we can cover the heterogeneity by having a panel.
If you want to
Yes. I think we are still operating under the premise that early detection increases the chances of cure and the chances of better survival statistics. So given that, for instance, in our own client, the peaks are between 25 and 35 for breast cancer, and a second peak at 35 and 45. If you look at those peaks, you find that mammography, which is the standard gold for screening, is actually not useful at those ages that are imperative for us, where the women are best needed in the family. And these are the places where our women are being hemorrhaged out of the system due to breast cancer. So multi-detection tools would definitely be useful to us that are not going to wait till they are 40, when you're assuming that the breast density would have, come down enough for the mammography to have more sensitivity. We have resorted to use ultrasound for doing mass screening, clinical breast examination. So if we have an ancillary tool that can accompany us to the communities to harness earlier cases, I believe that it should improve morbidity and it should improve mortality. Again, if you look at it, when we go for community services, we find full-blown fungating breast cancer lesions. Is that what? How is that going to continue to help us if we just fold our hands and wait till the women are 40? Even then, most of them are paying out of pocket. They are not going to come for mammography. So I believe that there is a need for some disruptive efforts to be put in place to take both the message and the service to the people where they are located. When my colleague from Egypt was making his presentation, I wanted to ask him, because in 2009, we had invited them to our International Cancer Week, because Egypt was involved in mobile screening solution. And they were making real, waves, screening huge amounts of people in collaboration with the government, who were, assisting to make sure that the screen positives were also being handled. So what I'm saying is that when we look at all of it, I believe that it is very, very important that we should embrace multi-detection. Yeah.
Sorry, we've got to.
Yeah. Well, okay. One last. It's a fascinating debate altogether. I'm really enjoying to hear this, because I do a lot of my work in early detection, and I'm really wondering about there's different aspects to all this. I'm interested in colorectal cancer. Colorectal cancer starts as a little pit, and then it grows into a little polyp. And it might take 10 years before it actually becomes what we call a cancer. And then it still takes a long time before it comes down the stem and escapes into the bloodstream or whatever. And during that time, you think there's got to be, in that 10 years, there's got to be an opportunity to identify this early. I'm very lucky. My brother Jeremy, after my diagnosis, my brother Jeremy had a colonoscopy. It removed a stage 1 cancer. Because he was considered to be high risk, because I had it, my grandmother had it, things like that. So there's this risk aspect which can build into this, and I'm really thinking about how MCED can become part of that picture I'm on a big project called BALSTAR, which is looking at refining the FIT screening program in the UK with risk stratification. Changing a screening program is a massive, massive challenge. I mean, they've talked about introducing MSED screening following the Gallery trial in the UK, and Charles Swanton said it is just such a massive thing to try and introduce this as a screening program. But if we can do risk stratification and identify who's more likely to benefit from this, then the chances of getting an inroad there, and it'd be a cheaper way. It's a bit like saying if you use it for symptomatic, that's one way of risk stratification. People come in with various symptoms, abdominal symptoms, that kind of thing, gut symptoms, then they are self-selecting in a way where you might actually start to make an inroad into this kind of thing. Screening in the UK gets about 10% of the colorectal cancers. Yet most of the people who have colorectal cancer diagnosed are in the screening age and are taking part in screening. You know, that is the conundrum about this, that it's a screening, it's a way there, but how effective is it? It'd be really interesting to see how MSED would compare to that.
Thank you. So we're coming to the end of this, and I would like to give the opportunity to each one to make some concluding remarks, in addition to reflecting also on your observation. And what I will ask you is also to reflect on the fact that is there a dichotomy between multi-cancer early detection and single cancer early detection, or can they go together or enhance each other? And of course, there are challenges. If you are in Nigeria where people don't want to show up because there's no treatment, and then you go with such a program, treatment is necessary. If people don't have any prospect of treatment, they won't come, irrespective of how sensitive or specific your test is. Cost is an issue, everything together. So if you can conclude by max 2 minutes, something that you don't want us to forget that you were here.
Yes. So the main question comes up, how much does the patient want to know? If you give them a test that is for screening, then it had better be extremely specific and at least highly sensitive. So these two facts hardly ever go together in a test. Usually, if it is highly sensitive, it is not very specific. So then the fear factor comes in. What have I got? And we can't tell you because we don't know where it is. That question is a very loaded one. And so, which is why at the present time, I feel very safe in having a screening test like an ultrasound with AI to tell me that there is a lesion there, and I will tell you whether it's benign or malignant. And that we can tell with great surety, and therefore now you can go into treatment or not into treatment, etc. So this aspect of balancing sensitivity and specificity becomes a big issue for us in this particular area. So for each of these cancers, methylation markers seem to be highly potent and highly sensitive in order to be able to distinguish between benign and malignant. So having very tight markers, selecting them very carefully, and testing them extensively. We first test in hundreds of tissues, then we test in the plasma or whatever, and we take just 1 milliliter of plasma. For our lab test, we take only 300 microliters. So if we didn't depend on Cepheid or any other company, we could do a lab test. It'll need more money and more investment and a company to go behind it, etc., which is something that I'm not willing to invest time in right now. So the bottom line is that for any test, we have to balance sensitivity and specificity and see how much are you willing to give up. For instance, how much, if you are told that you have cancer but your biopsies show that you do not have cancer, you would like to know which site should I look at. For me, that is important.
All right. Thanks. Mao.
So I still go back to my landline phone, cell phone, and the smartphone. So in terms the the MSAT and what you have today for the screening probably 10 cancer types, they will coexist in your country because you already have the landline phone. It is a good phone, and especially for the emergency if the cell phone tower just shut down. So and always for a particular cancer type, so like a colonoscopy is always going to be better than MSAT because MSAT is very much balanced to have very good specificity, and you will have a pretty poor sensitivity if you do that, and especially for early disease. And still go back to this, landline phone, cell phone, smartphone. If we talk about Africa, right? If we talk about the rural area in China, there is no landline phone. I can tell you, there is no diagnosis. And what we want to do is early diagnosis. It's diagnosis. We are not talking about screening. And I can guarantee you, Africa will leap to the smartphone. They will never have landline phone. They will never. If you look at the infrastructure, you need expertise, the people. No, it's not going to happen. They will jump to smartphone no matter what you want it or not.
Thank you.
They will be there.
Yeah, thanks.
So I don't believe there is a dichotomy. I think there should be, there's room for having them as complementary, which is of course what we're using. We all know that all of them, mammography, ultrasonography, everyone has its specificity issues. So we just need to do what? Embrace and utilize what is available in our community. Looking at Nigeria in particular, we are talking about out-of-pocket payment. So when you're doing screening, you aim to take the screening to the people because even access in terms of transportation is a problem. It's so high. Nobody who is well will engage in coming out to go and get screened. So we should offer them a screening too. So we even use clinical breast examination as screening. And it's a kind of sorting out who you should follow up for the next level. So if we have a complementary multi-detection tool, we take it along, do that. Ultrasonography, as mundane as it sounds, perhaps in high-income countries, is not mundane. Even the workforce, to make sure that they're going to be able to utilize the mammography. So what I'm advocating, for instance, the high-risk groups, you identify through history. So you scale them. We don't use MRI except if somebody can afford it. So what we do is still offer ultrasound and whatever that is available. So if we have a multi-detection tool along with ultrasound, along with clinical breast examination, we are able to tide our patients, our population to the age of 40 when mammography can be also added on as a way. Then for the high-risk groups, we are looking at to do a risk factor test, genomic risk factor test. It's as high as 500,000 naira, Nigerian money. Can they afford? Very few people can afford it. So if we are partnering with an institution as reputable as Stanford, and we're already contributing up to 22,000 images within a space of just 6 months, we can contribute more and make sure that when they come up with the image genomic solution, we can actually benefit from doing genomic studies of our population and getting the people that have the risk factor to have benefit. Yeah. Thank you.
Harry, is the data telling us to be cautious or excited?
Yeah, that's a nice last phrase. Cautiously exciting. Yeah, I was a bit struck by the firefighters. Unfortunately, I didn't know those data until last night. So I think indeed we have to embrace all evidence-based screening programs where indeed the benefits really outweigh the harms. And fortunately, we have that. And that can be clinical breast exam in countries that don't have so much mammography machinery. We have shown that it's really interesting. CT lung cancer screening is really the next. But I agree, there should not be a dichotomy. So we should think about ways to include this multi-cancer early detection test. Again, not to replace the existing ones. I think we will not have that. We should not have that, I think. But indeed, as you indeed say, finding some cancers earlier that otherwise would never have been detected earlier is a benefit. So let's be clear about that. So yeah, cautiously exciting. Thank you.
Thank you very much.